September is Afib Awareness Month. I'm happy to team up with my friends over at Cardiovisual alongside the other awesome educators that you're seeing featured. Here, I'll be reviewing rapid identification of Afib on the ECG from a single lead basic rhythms and nursing perspective. Now, Afib is the most common arrhythmia in the adult population and accounts for over 30% of arrhythmia-related hospitalizations by some accounts. All of this is to say that we should expect to encounter it at some point and be well prepared to recognize the expected changes on the ECG. So, if we encounter a rhythm with no discrete P waves that's irregularly irregular, the chances are very high that it's atrial fibrillation. Irregularly irregular simply indicates that we have no way to make an educated guess or predict where the next R wave is going to land. Now, the baseline here may be coarse and erratic, or it can be extremely fine and near isoelectric. This is why I'm not a big fan of necessarily relying on fibrillation waves at baseline, although they may be present and more evident in some leads, like V1 for example if you're looking at a 12 lead. This irregular pattern that we're seeing is a result of the AV node being bombarded with somewhere between 300 and 600 atrial impulses each minute. Thankfully, we have the AV node to play a protective role as gatekeeper in these instances. Now, ECG appearances can vary greatly in Afib, from rate controlled to having a rapid ventricular response. The QRS may be narrow with typical supraventricular conduction, or it may be wide if an underlying conduction delay is present. But what we expect all of them to have in common is, say it with me, a rhythm that's irregularly irregular without any discrete P waves. Now, of course, it is possible to have atrial fibrillation with a complete heart block, or underlying atrial fibrillation with a ventricular paced rhythm, yes, but here we're sticking to the basics. Now, on screen are a few more potential appearances that atrial fibrillation may take. But as long as we remember what each of these have in common, then we're on track to set ourselves up for appropriate identification. The goal being so that we can report changes to the provider quickly and achieve the most appropriate treatment outcomes for our patients in the most timely manner possible. I hope you found this quick review equal parts entertaining and helpful. And I'll go ahead and turn it over to my friends here for more information.
Computer ECG interpretation, we all rely on this to some degree, but what is your understanding of how accurate they are? Well, let's start off with a case. An 86-year-old female was seen in the ED for several days of intermittent dizziness and syncope, and she had an ECG done that was interpreted as atrial fibrillation. Now, her workup, including a head CT scan, was normal, and she was discharged home with a diagnosis of Afib on Eliquis. Now, she represented about 48 hours later with a massive GI bleed, almost exsanguinated, had to be intubated emergently, received massive blood transfusions, and was admitted to the ICU. So, what went wrong? Well, the physician relied on the ECG's machine interpretation of Afib and missed the diagnosis of a second-degree type 1 heart block. So let's focus in on limb lead 2 of this ECG. Now note the progressive lengthening of the PR interval, eventually resulting in a dropped QRS. Note that the PR interval preceding the dropped QRS has the longest PR interval. Finally, note that the PR interval following the dropped QRS has the shortest PR interval. Now, this failure obviously resulted in a bad outcome, and in this study in 2017, the authors Schlaffer et al. Showed that by far Afib is the most common error made by ECG machines and responsible for up to 40% of both false positive and false negative STEMI diagnosis. Now, the authors concluded that misdiagnosis due to ECG computer interpretations may in fact account to up to 10,000 adverse effects or even deaths each year.
October is Atrial Fibrillation Awareness Month, and I'm honored to have been invited by Cardiovisual to give my 2 cents on a specific subtype of atrial fibrillation that has recently been one of the main focuses of my research activity, postoperative atrial fibrillation following cardiac surgery. Hope you enjoy this. Postoperative atrial fibrillation is the most common complication after cardiac surgery, increasing in hospital stay and costs, and has been associated with adverse cardiovascular events, including stroke, heart failure, and mortality. Overall, about 30% of cardiac surgical patients will develop postoperative atrial fibrillation. It is usually a self-terminating event occurring 2 to 4 days after surgery. The main pathophysiological mechanisms include pericardial effusion and inflammation, autonomic neuromodulation, and atrial structural alterations. The main strategies for prevention and treatment encompass antiarrhythmic drugs and anticoagulants, overdrive atrial pacing, left posterior pericardiotomy, and a bunch of other experimental tools. Posterior pericardiotomy consists in a 5 cm incision of the posterior pericardium that drains the pericardial space into the left pleural cavity. We have recently conducted a randomized clinical trial showing that it significantly reduces the incidence of postoperative atrial fibrillation, basically at zero cost.
Hello everyone, my name is Matt Holden and I'm one of the co-founders of Scope, and here we're going to talk briefly about AFib for AFib Awareness Month. So on your monitor here, you can see an irregular rhythm with no P waves, and the rate is around 79 beats per minute. This will be your typical AFib patient. So this is our normal heart. You can see that the atria are able to contract in a coordinated way, which allows blood to enter our ventricles. From here, the ventricles can contract to send blood to our lungs and to our body. Now we get into our AFib heart. The atria are beating chaotically as there's multiple sites all creating impulses. This causes some of the blood to stay inside of our atria and pull into something called our left atrial appendage, which you can see by our black arrow. This pooling and poor contraction increases the chance of a clot to form inside of the atrial appendage. This clot is unstable and can be released and cause a stroke, which is one of our big worries with our AFib patients. So, once again, my name is Matt, and I would like to thank my friend Dialed Medics for creating the great rhythm strip you saw at the first slide.
Hi, my name is Tuna Tekin. I'm a medical doctor from Frankfurt, Germany, and I welcome you to this brief presentation on direct oral anticoagulants, or short DOACs, used in the management of atrial fibrillation. In the next 3 minutes, we will explore 4 commonly prescribed DOACs: apixaban, rivaroxaban, edoxaban, and dabigatran. We will discuss how they work, potential side effects, and their dosage adjustments necessary in cases of renal failure. Let's start by speaking about DOACs in general first. DOACs are a group of medications used to prevent blood clot formation in individuals with atrial fibrillation, a common heart rhythm disorder. They work by inhibiting specific clotting factors in the blood, offering several advantages over traditional anticoagulants like warfarin. The next question to answer is, how do DOACs work actually? There are 2 locations in the clotting cascade in which the DOACs show their effect. Apixaban, rivaroxaban, edoxaban, they are all 3 direct inhibitors of the factor 10A, a key player in the blood clotting cascade. Dabigatran is different. It inhibits thrombin directly, which represents the factor 2A in the clotting cascade. Now let's discuss potential side effects of DOACs. While generally well tolerated, common side effects may include minor bleeding, nosebleeds, bruising, or gastrointestinal symptoms. It's essential to report any unusual bleeding to your healthcare provider. So, last but not least, let's talk about renal function and dosage adjustments. For patients with impaired renal function, dosage adjustments are crucial. The kidneys play a role in clearing DOACs from the body, and the reduced kidney function can increase the risk of bleeding. Your healthcare provider will adjust the dosage accordingly. Thank you for watching this brief overview of DOACs used in atrial fibrillation. If you have any questions or concerns, don't hesitate to reach out to your healthcare provider for personalized guidance.
Hello everyone, my name is Chris Tesche and I'm an interventional cardiologist from Munich, Germany. Today's topic of this great collaboration is the treatment of atrial fibrillation. Briefly, The treatment of AFib can be divided into heart rate control and rhythm control. Heart rate control means slowing down and controlling the heart rate during episodes of atrial fibrillation. Therefore, we use medications including beta blockers, calcium blockers, and digoxin. On the other hand, rhythm control means maintaining the rhythm in its normal state, the sinus rhythm. Medications called antiarrhythmic drugs help us to control the heart rhythm. Additionally, electrical cardioversion, an electrical shock to the chest done under general anesthesia, can restore the heart rhythm's normal electrical rhythm. Catheter ablation, a catheter-guided ablation procedure to destroy areas of the heart that's causing the abnormal rhythm, is the only way to permanently eliminate atrial fibrillation.
Welcome to an overview of how atrial fibrillation is related to heart failure. First, you need to understand that about 20% of cardiac output is lost in AFib. And that's really, if you look at the EKG, you see that you lose your P waves from sinus rhythm to AFib. Now you have these fibrillatory waves, and that's where the atrial kick is really lost and where it comes from. So why does this happen? Well, the loss of the atrial kick accounts for about 20% of your cardiac output. So that's about 20% of blood that moves from the left atrium to the left ventricle that's lost, and you also have increased heart rate and a decreased LV filling time. So can this loss in cardiac output affect LV function? Yes, about 20% is lost from that atrial kick that should go into the left ventricle. One way to showcase this is look at this juggler. If I give him 4 balls to toss, then he's going to have 4 balls to move around, right? But if I only give him 3 and I take away 1, then he's only going to have 3 to move. So the example of this with the left ventricle is that the left ventricle can really only move forward the blood that it receives from the left atrium. So if you take volume away, then it's going to lose volume of what it's supposed to provide to the body. If we draw this in our heart diagram, you'll see 4 arrows for blood coming from the left atrium, and those 4 arrows would go left ventricle out to the body. In comparison, if you only have 3 arrows, 3 go into the LV and out, so you're missing some. No matter how much blood comes into the left atrium, none of it's going to get out. You might see, consequently, left atrial dilation, where the annulus dilates, the leaflets get separated, and that can lead to mitral regurg or tricuspid regurg if it's on the right side. In summary, an AFib's link to heart failure, some things that you are going to see include decreased atrial contraction, decreased LV filling, decreased cardiac output, and that reduction in atrial contraction really contributes to the increased volume retained in the atrium, increasing atrial dilation, which increases the risk of AV regurg, which are your mitral or tricuspid valves, and that reduction in cardiac output might be the cause of your fatigue symptoms. Thanks for watching.
Hey, Dr. J here. As you know, September is AFib Awareness Month. I'm happy to be working with Cardiovisual and many other educators to talk about AFib during this month. I'm going to focus on the management of AFib and heart failure, particularly focusing on the inpatient setting. Let's go. Let's talk about the relationship between AFib and heart failure. There are 2 types, right? Sometimes AFib can cause heart failure. That's called tachycardia-mediated cardiomyopathy. The clue is that basically when you look at the echo, the LV is not dilated. That suggests an acute process. By far, this is not the most common type. Most common type patient has chronic heart failure, HFpEF or HFrEF, increased filling pressures, increased left atrial size, leading to chronic AFib. That's the most common type. Let's go over management now. For the sake of time, I'm not talking about anticoagulation, but mainly the strategies in the hospital. So first of all, if they're unstable, you got to cardiovert them. If they're stable, now you have 2 strategies. You have rhythm versus rate control. So rhythm, first of all, you ask yourself, what am I treating? Am I treating HFpEF or HFrEF? Let's talk about the focus on the rhythm. So a good one, if they're trying to rhythm control, you can use amiodarone for both HFpEF and HFrEF. It's going to be safe. We're going for the rhythm strategy. If you're going for a rate strategy, that's where things are a little different. Let's talk about HFrEF first in our rate strategy. You can use amiodarone, you can use beta blockers, or a good old-fashioned DIG. Now, what about HFpEF rate strategy? You can use, again, beta blockers, amiodarone, digoxin, calcium channel blockers. That's where you can use calcium channel blockers. You cannot use calcium channel blockers for HFrEF. Let's go on to catheter ablation. Guidelines say now that catheter-based ablation for AFib is a 2A recommendation, and if you fail medical therapy, it's a 1A recommendation. Hope you found this helpful.
Working up an AFib patient in the outpatient clinic. What should you start with? My name is Jen Carlquist, and I am a full-time cardiology PA of over 16 years, and I also work in the emergency department. Obviously, the first place to go is the EKG and making sure that you actually do have AFib. One interesting thing is that in the PR interval, often it will be read as an asterisk. There won't be a number there because the machine is actually not seeing any P waves to measure. That's clue number one. Of course, you're also looking for the regularity, and you will see that classic irregular rhythm. The next thing you need to do is you need to make sure that they're actually rate controlled, because you don't want them ticking along in the 130s and 140s, because that can lead to heart failure. Speaking of heart failure, that is one potential risk factor for AFib. So we absolutely need to get an echo. On that echo, in addition to looking at the EF, I'm also looking at the size of the atria. When you have enlarged atria, right or left, it does predispose you to having AFib. In fact, the common saying is that it's not a matter of if, it's a matter of when. But looking at that atrium, we're also going to use the size to determine if they are a candidate for an ablation. If a patient has a very elevated size, so moderate to severe, they're probably not going to be as good of a candidate for ablation. The next thing we need to do is get a stress test of some sort, because AFib can be what's called an ischemic substrate, meaning that significantly occluded coronary arteries can cause new AFib. Before the patient leaves the visit, you also need to do what's called a CHADS-VASc2 score, and you can easily find this as a calculator online that's free using QXMD. Once you do their calculation, you're looking to see if they're a 2 and up. If they are, then they are a, quote, no-brainer, end quote, for anticoagulation. Of course, you're going to balance this out using the other score you can find in that calculator called the HAS-BLED, and if it's over 3, then you absolutely want to reconsider using anticoagulation. Ultimately, though, the goal is to get the patient out of AFib as soon as possible, one way or another. A lot of times, we'll start with a cardioversion after they've been on anticoagulation for some time, at least 3 weeks, most often is 4. But if they're super symptomatic and we just can't get them feeling better in that month period, and they're not willing to hang in there, then you can schedule a TEE and make sure there's no clot, and at the same time do a cardioversion. The biggest part of the visit, though, is really just getting into educating the patient about what's going on and reducing any triggers they may have.
Hello everyone, my name is Simon. I'm a Danish cardiologist, and I'm happy to inform you about atrial fibrillation here in September together with my colleagues. And I'm going to show you what most commonly you see on the echo of this type of patient. One of the most commonly normal findings is atrial enlargement. As you see here in this patient, both the left atrium and the right atrium is enlarged. And in this case, we can see that the ejection fraction of the left ventricle is normal. In this other case, with a patient with atrial fibrillation, you can see the left ejection fraction is severely reduced. If you have doubts about the size of the left atrium, you can trace it, and if it is above 44 milliliters per square meter, it is severely enlarged, as in this case where it is 47 milliliters per square meter. The last thing I want to tell you about chronic atrial fibrillation is that you can develop a secondary mitral regurgitation. It is where the atrial enlargement do that the mitral valve leaves cannot reach each other, and then you will get a very sometimes big regurgitations jets, as you see here, and it is not a valve disease but a disease due to the enlargement of the left atrium.